Bismillahirrahmanirrahim. Assalamu alaikum everyone. This is Dr. Mubasshra and today we are going to discuss a very important topic, that is spontaneous bacterial peritonitis in liver cirrhosis, which is commonly abbreviated as SBP. SBP is defined as spontaneous bacterial infection of ascitic fluid which occurs in the absence of an apparent intra-abdominal source of infection. It is seen in patients with ascites, which is caused by chronic liver disease. It is a common and severe complication of cirrhotic ascites. Regarding the incidence, SBP can occur in up to 30% of patients of chronic liver disease and can have 25% in hospital mortality rate. The incidence of SBP is more than 40% in patients with ascitic fluid total protein of less than 1 gram per deciliter, probably due to decreased ascitic fluid opsonic activity. Regarding the pathophysiology and mechanism of SBP, bacterial translocation is the presumed mechanism for development of SBP. The enteric bacteria and gut flora translocate against the gut wall or mesenteric lymph nodes, which leads to bacteremia and seeding of the ascitic fluid. What is the etiology of SBP? All cases of SBP are caused by monomicrobial infection. The most common pathogens are enteric gram-negative bacteria, for example E. coli, Klebsiella pneumonia, or gram-positive bacteria, that is Streptococcus pneumonia, Viridin streptococci, Staph aureus, Enterococcus species. However, anaerobic bacteria are not associated with SBP. If more than 2 organisms are identified, secondary bacterial peritonitis due to perforated viscus should be considered. Regarding the signs and symptoms of spontaneous bacterial peritonitis. So, SBP is symptomatic in 80 to 90% of cases. However, it may be present in 10 to 20% of patients who are hospitalized with chronic liver disease, sometimes in the absence of any suggestive sign and symptoms. Fever and abdominal pain are the most common symptoms in almost two-thirds of the patients of SBP. However, presentation is subtle in many cases. For example, a change in mental status due to precipitation or exacerbation of hepatic encephalopathy or a sudden worsening of kidney function can be there. Physical examination shows signs of chronic liver disease with ascites, and abdominal tenderness is present in less than 50% of the patients. Now let's discuss about the laboratory findings in SBP. The most important diagnostic test is abdominal paracentesis. Paracentesis within 12 hours of admission reduces mortality because of early detection of SBP. Blood culture bottles should be inoculated at the bedside. An ascitic fluid polymorphonuclear count of more than 250 cells per microliter, that is neutrocytic ascites, is presumptive evidence of bacterial peritonitis. The percentage of polymorphonuclear neutrophils is greater than 50 to 70% of ascitic fluid WBCs and commonly approximates 100%. Culture negative neutrocytic ascites is present in 10 to 30% of patients with neutrocytic ascites. These patients should be started on empirical antibiotics. So, ascitic fluid should be sent for cell count and differential. Now let's discuss about the differential diagnosis of spontaneous bacterial peritonitis. So the most common differential diagnosis is secondary bacterial peritonitis. Secondary infection may be by intra-abdominal infection, and the causes of intra-abdominal infection include appendicitis, diverticulitis, perforated peptic ulcer, and perforated gallbladder. So, how to distinguish between SBP and secondary infections? Ascitic fluid total protein, LDH, and glucose are useful in differentiating between SBP and secondary infections. Up to two-thirds of patients with secondary bacterial peritonitis have at least two of the following, like for example, glucose level of less than 50 mg per deciliter, elevated LDH that is more than that of serum, elevated total proteins more than 1 gram per deciliter, ascitic neutrophil count of more than 10,000 per microliter, and the presence of multiple organisms on ascitic fluid gram stain or culture. And this is diagnostic of secondary peritonitis. Now let's discuss about the diagnostic investigations for secondary bacterial peritonitis. If secondary bacterial peritonitis is suspected, abdominal CT scan of upper and lower GIT should be obtained to look for evidence of intra-abdominal source of infection. However, if CT findings are negative and still there is strong suspicion of secondary peritonitis, then repeat paracentesis should be performed after 48 hours of antibiotic therapy to see if polymorphonuclear neutrophil count is decreasing or not. And neutrocytic ascites. There are other causes of neutrocytic ascites, for example, peritoneal carcinomatosis, pancreatic ascites, and tuberculous ascites. Now let's discuss the treatment of spontaneous bacterial peritonitis. Empirical therapy, that is commonly third generation cephalosporins, are given in SBP, and these include cefotaxime 2 gram IV every 8 or 12 hourly, or we can give ceftriaxone 1 to 2 gram IV every 24 hours, or combination of beta lactam or beta lactamase agent, for example ampicillin sulbactam 2 gram or 1 gram IV every 6 hourly. Now what is the treatment duration in SBP? Although the optimal duration of therapy is unknown, however, empirical course of antibiotics is recommended for 5 to 10 days or continued treatment until the ascites fluid polymorphonuclear neutrophil count decreases to less than 250 cells per microliter. Now the question is, if the patient does not show significant clinical improvement, what is next? So, the patients who don't show any significant clinical improvement after 5 days of empirical antibiotics, they should undergo repeat paracentesis to assess treatment efficacy. If ascitic neutrophil count has not decreased by 25%, antibiotic coverage should be adjusted according to culture and sensitivity results. Also, secondary causes of peritonitis should be excluded. If ascitic polymorphonuclear count has decreased but remains more than 250 cells per microliter, antibiotics should be continued for additional 2 to 3 days before paracentesis is repeated. Now the question is, what is the most effective treatment of recurrent SBP? And the answer is liver transplant. Now let's talk about the treatment of secondary bacterial peritonitis. Broad spectrum coverage for enteric aerobic and anaerobic flora should be given with third generation cephalosporin and metronidazole. Kidney injury develops in up to 40% of patients in SBP, and it is a major cause of death. So the treatment is IV albumin, which increases effective arterial circulatory volume and renal perfusion, decreasing both kidney injury as well as mortality. IV albumin dose is 1.5 gram per kg on day 1 and 1 gram per kg on day 3. It should be administered to patients who are at high risk of hepatorenal syndrome. And the second treatment is non-selective beta blockers, but it increases the risk of hepatorenal syndrome in patients with SBP. So they should be discontinued due to their adverse impact on cardiac output, renal perfusion, and long-term survival in advanced cirrhosis. Now let's talk about prevention of SBP, prophylactic therapy. Up to 70% of patients who survive an episode of SBP will have another episode within 1 year. So, what we give in prophylaxis? Oral once daily prophylactic therapy with ciprofloxacin 500 mg or norfloxacin or trimethoprim sulfamethoxazole has been shown to reduce the rate of recurrent infections to less than 20%. The question is, what are the indications of prophylaxis in SBP? So, prophylaxis should be considered in patients who have not had prior SBP episode but are at increased risk of infection due to low protein ascites. That is, total ascitic protein is less than 1.5 gram per deciliter with impaired kidney function. That is, serum creatinine is more than 1.2 gram per deciliter, or patient has decompensated cirrhosis of child pug class C. So, prophylactic antibiotics are associated with low risk of SBP as well as hepatorenal syndrome and ultimately mortality. Now, let's discuss about the prognosis of SBP. The mortality rate of SBP is 25%, but early diagnosis and treatment leads to decrease in mortality rate to less than 10%. Since majority of patients have underlying severe liver disease, many may die of liver failure, hepatorenal syndrome, or bleeding complications of portal hypertension. So this is all about SBP. I hope it is helpful for you. Stay blessed. Thank you so much for watching. Allah Hafiz.